Okay, so good afternoon, good morning, good evening, good night. I hope we will have nobody taking a nap during this session. I think it's great having an amazing gathering and amazing speakers with us here today. And it's great to have so many of you looking and listening at us. It's really great to have the American Thoracic Society and Union putting together an amazing webinar and looking at ending and eliminating TB. Depending on your time zone, one more time, welcome to this session, which is the fourth and final session in the American Thoracic Society and Union joint webinar series. My name is Lucica Ditiu. I'm the Executive Director of the StopTB Partnership. My colleague and friend, Dr. Tereza Kasaeva, the Director of the WHO Global TB Program, will join. There are some little difficulties in her joining, so I will just go ahead. I just want to re-emphasize that we all want to thank the American Thoracic Society and the Union for this collaboration, as well as the panel of speakers for providing their insights into TB elimination. Before we begin, I have a few brief notes and reminders. I think we are all up to our heads with the Zoom calls and everything, but just to remind that we have muted all participants due to the large number of registrants. If you have a question, and I hope you have a question, we encourage you to submit it via the chat feature on the webinar platform. This webinar is being recorded and will be made available to all registrants. And the archived webinar will also be posted on the American Thoracic Society website. So please feel free to share the link with your colleagues. Now, we have an important aim of this webinar today, and that is to discuss what steps we need to mobilize for ending tuberculosis. So this webinar will feature 4 speakers in a roundtable discussion. Our first panelist will be Dr. Eliud Wandwalo. He's the head of tuberculosis at the Global Fund, a very important and challenging and job. Our next panelist is Dr. Jamal Ahmed. He's the acting global coordinator for polio detection and interruption at the World Health Organization. Our third panelist is my good friend Yuliia Kalancha. She is the executive director of the TB Europe Coalition. And we have as well with us, and very happy to have him with us, Professor Habibe Millat. He is the member of the Bangladesh Parliament and the chair of the Bangladesh Parliamentary Forum for Health and Well-being. And with this, I want to welcome all our speakers. And we will have a few opening remarks from myself, from my co-chair Tereza, and then we will move on opening questions for each panelist. And believe me, and I very much appreciate our colleagues from ATS and the Union, we have good time for discussions, because I think we all are tired of sessions in which you have a lineup of speakers, and at the end, when you want to ask the question, time is over. So this time, we have plenty of time for discussions. So, but before going into that, as I said, we have few minutes of opening remarks, and while we are waiting for all of you to join, and I am happy to see my colleague and friend Tereza joined. In our flow of the presentation, Tereza, you go first with your opening remarks around about progress on SDG TB targets. And for the audience to be aware, I will follow after Tereza, and I offered myself to actually have a point on why I think we will not reach the SDG targets. Now, I actually think and hope we will reach them, but we felt it will be more interesting if we have this kind of points in which somebody plays the devil advocate and says, no, we will not. But anyway, so without further ado, Tereza, if you can go ahead on the progress on the SDG TB targets.
So thank you very much. Dear colleagues, friends, warm greetings from the WHO, from the Global Tuberculosis Program. headquarters, Geneva. So happy to co-chair and join my colleague and friend Lucica today at this very important webinar organized by Union and ATS. So much appreciate your efforts. It's timely, important, and thank all the panelists and audience joining us today. So we'll try to be brief and present to your attention overview of our current status and progress towards our targets. As we all know, TB remains one of the world's top infectious killers, claiming close to 4,000 lives a day and 1.4 million lives annually. But I'm referring to the data of the last year report, and we are now already at the final stages of the preparation of the new data. So I'm not disclosing it now, but I must say that this status unfortunately will remain, and our situation with the TB mortality will become even worse, unfortunately, due to impact of COVID-19. So we know very well about our ambitious targets, milestones of the NTB strategy and of the UN high-level meeting political declaration. Even before COVID-19, the world was not on track towards reaching that, but still, with joint efforts, we've made some significant progress, which reflected in a 9% reduction in incidence between 2015 and 2019, and 14% drop in death in the same period. So, of course, it's not enough, but this is again the results of huge efforts, and we should take into consideration chronic lack of funding for all our efforts. So, according to WHO again global TB report, there were nevertheless 2 regions which I would like to bring, especially regions who managed to reach our NTB strategy milestones with 90% of decrease in incidence and 31% decrease in death. It was European region. Another region is African region, who made also significant progress, respectively 16% reduction in incidence and 19% reduction in death. It shows clearly that our milestones are ambitious, but they are achievable. And these 2 examples shows us, and also, of course, examples from the countries. So, and then when we hear some criticisms that we are too ambitious, so we should be ambitious, and this is the only one way to push, to move forward, and to have a progress. So, if we will look at the progress towards our high-level meeting political declaration targets, over 14 million people were treated for TB in the period of the 2018-19, and it's 35% of the way towards our 5-year targets of 40 million. 6.3 million people started TB preventive treatment for the same 2 years. It's 21% of the progress. And if we will look at this data on TPT in more details, you will see that mainly this progress is due to the coverage of the people with HIV with the TB preventive treatment. The rest, a cohort of households with 24 million, the progress is much more modest, less than 1%, and it clearly shows that this area is underfunded and that we should do much more. And finally, our financial gaps, and we have targets, 13 billion we need annually to be on track and to provide progress, and we've managed to bring only half, 6.5 billion. TB research area and innovations is again chronically and even more badly underfunded. Now, if we will look at the disruption caused by COVID-19, they're also very concerning and significant. We are monitoring, as you know, the beginning from the beginning of the pandemic on monthly basis TB case notification. and the disruption is severe and continuing. We can see, and collating data from more than 90 countries, that from the 7.1 million coverage, we dropped to slightly more than 5 million coverage last year. So these drops in notification are significant, as you could see, and it leads to the global drops in the notification, around 21%. In some of the countries is 45% and more. So we should highlight it, we should bring this, and also we can see not only a disruption, but also allocation of the TB specific resources and including a workforce from the TB programs. But in the same time, we can see how heavily and meaningfully we are contributing as into this progress. So another important thing I would like to bring as one of the achievements and following the commitments of the high level meeting is that oh my goodness, Kasiana, I've pressed somewhere on the wrong button. How I can?
We can hear you and see you.
So sorry, it was
no, it's okay.
I pressed the wrong button, but it's good that I'm staying here. So I would like to bring the example of the following our commitments. We've developed and adopted unanimously new global strategy for TB research and innovations, and now would like to encourage countries to follow also their commitments. So further progress will depend, of course, on our joint efforts and also on the implementation of the vision of the multi-sectoral collaboration, meaningful engagement and accountability. And again, we have a clear framework and countries are working very closely. Due to the impact of the COVID, is becoming more clear that without addressing social determinants, economic circumstances, we will not be able only focusing on the health specific issues move forward and to provide further progress. So there are pluses, minuses, there are a lot of challenges, but it's not time to be discouraged. It's time to consolidate, double, triple our efforts and move forward. And by chance we are with Lucica in black and white, but in fact we are unanimous, and I hope that Lucica will support many of our points. We are looking forward to the high-level meeting in 2023. So, and we will receive another opportunities to bring attention to our problems. So I will stop with this and we'll give floor back to Lucica. Thank you.
Thank you so much, Tereza. And yes, I actually, we are here divided into groups dressed in white and groups dressed in black. But obviously, I don't think it has anything to do with our desire and hope that we will end the disease. But as I said, and thank you, Tereza, for sharing these incredible clear points. I will actually, for the sake of an argument and to generate discussions afterwards, because the intention is to really make sure that you guys listening have some food for thought. I will go into something that actually I don't believe, but I think COVID may be slightly bitter though in having a lot of hope in general. So I will actually say why I think that we will not reach these targets. So and I will try over 5 minutes to do that. As I said, I hope I will be wrong, but you never know. So a few points to make. And actually, what I'm saying is not an exaggeration, is a reality. COVID pushed us back. COVID pushed us back at the levels of 2011, 2012. We don't even know if the situation is not even worse, and that's why looking forward to the data that WHO will release later, in October, beginning of November, because it might be that the situation is even worse than we expected. To reach the 2030 targets, which are are speaking about ending TB, we are not aiming to eliminate TB. Ending TB means basically going to the entire world at a sort of cutoff level. It doesn't mean we will have 0 cases of TB in 2030, but we will have a smaller number in each country that is somehow equivalent with what it means ending TB. Elimination means that we still have a number of cases, and the eradication, it takes us at a completely different level. And we don't even have that big aspiration about eradication till at least 2050, which is something that we, for several of us will be slightly too late. But for 2030 targets, where we speak about ending TB, to obtain that, obviously, we need to be on a path to reach that level, right? We need to observe a decrease. And what we saw a bigger progress in 2018, 2019. But then with 2020, we are back in basically an increased number of people that die with TB. Anyway, TB was killing more than HIV and malaria together, was the biggest infectious disease killer, and now continues to be at the forefront there with COVID. We see, therefore, an increased number of people that are not diagnosed and treated with TB. And as such, the number of people that we need to detect and put on treatment is actually higher. And the number of people that are missed from the services is probably going back to 4 or even more than 4 million. So we are not on track with that. So the numbers are not helping us. We have 1 year and 3-4 months to reach the 2022 targets. We are completely not on track for this. A big miracle needs to happen next year to do that. When I say it's in the realm of miracle, it's like all of us becoming mermaids and unicorns and running around. That's what I'm speaking about. Is not a medical miracle, but it is a miracle that needs to happen next year to be able to reach the UNHLM targets 2022. But we still have time till 2030, you will say. But I think, so one reason for me why is because we are so much off track and because COVID derailed completely our efforts. The second thing is that we have such a dramatic lack of resources in TB that it is like somebody is asking us to play football with, like, I don't know, Real Madrid or Barcelona team, which are fully trained, fully equipped, and we are playing in our underwear, barefoot, without being able to train ever, because that's what we have the money for. And I'm not exaggerating, but for the TB response globally, we barely go at around 45% of what we need if we want to aim to reach the targets. So when you plan to build a house, a full house, with half of the money you need to really build a house, we all say that without securing the resources, we can have ambition, we can run like mad, as I say in the field, we can die there, all of us. If the resources are not there, it's not possible. So my second reason is that we don't have the money, and I become very bitter and skeptical looking at what happens around with how the rich nations are treating the ones that are less rich in terms of access, in terms of availability of products, in terms of ensuring for everyone access to the right tools and the diagnosis. I'm very skeptical that we will get the funding and the tools that are needed to be put everywhere. The third reason is linked to this, is our tools are great, but because of the lack of money and lack of awareness, we don't have the ones that are needed or the scale that we need to end TB. We don't have a vaccine. The best timing for us to get a vaccine was, according to the global plan and according to the work of the colleagues working on the TB vaccine development, 2026, 2027. And that, even that, with a dramatic increase in the resources, which is not available. We know that without a vaccine, TB will not be ended. So, if we have the vaccine too late, by 2030, we will not be, you need time to roll out the vaccine. You see, even with the COVID, now that you have all the world mobilized, you see that the certain level of vaccination is not as exciting as we were all hoping for all the reasons. I'm not going even into the access part now. But the point is that we don't have the tools to end TB. We need a vaccine for that. And what we need is also, as I said, complete access of the people, of everyone, to the tools that we already have. Which brings me to the fourth reason, which is related to the fact that I am a firm believer that we will not be able to end the TB and reach the SDG targets without having really the people, the ones that are suffering, at the center of the intervention. And we all speak about people-centered interventions and so on, but what it really means is really having the communities and those that suffer deciding how things should be delivered and ensuring access for them, irrespective where they are, their income, geography, religion, beliefs, sexual orientation, and so on, vulnerable groups, and so on. And what I think we all observe is, because of COVID, I actually think that any progress in general on rights, stigma, gender, inclusiveness were actually rolled back. I think, sadly, the COVID and access to testing and access to vaccination globally showed an ugly part of us as a humanity, that we don't care about the ones that are weaker among us, and we just run with what we have. So I think it will take a lot of time to recover the ground lost in these aspects of rights and gender and stigma and access, equity, social justice. And I think without that, we will not be able to end TB, because TB, in general, I would like to say that TB is a disease that is affecting people that are the ones that are without a voice, that are not that visible in the society. And that's why it's so difficult to make the case for them, because they are the quiet, invisible ones. And unless we stand up for them and secure that the government will embrace and provide for them equally, like for everybody, it will be a long way to go. And I am afraid that it will take us 4 or 5 years just to go back where we were before, till we are able to reach the SDGs in 2030. And the last point on why I think it will be difficult, but again, I hope that I really hope I'm wrong, and is the fact that I feel that on the global health arena there are a lot of movements and changes. I think there will be a lot of turbulent years ahead in terms of how the different big platforms that are at global level in supporting public health or health interventions, universal health coverage, and so on, the nationalisms and the countries deciding more within their borders rather than going overall, and in collaborating with each other, we will see a lot of friction between this, that for TB, which is such a borderless disease, it's spread through air, it will be heavily affected unless we are able to rebuild again this cohesion. TB is an airborne disease. TB should be at the center of anything that it's about the preparedness for future airborne pandemics. What goes through the nose ends up in the lungs, and we as pulmonologists dealt all the time with the lungs in TB and constructed systems, hospitals around dealing with a disease spread through air and in the lungs. So that's why I hope that we will be smart enough to use these opportunities in building forward. Now, I will stop here because I can speak like that and you will all hate me, which it might happen anyway. I really hope I'm wrong, because I am a strong believer, and as StopTB partnership, as a human being and a medical doctor dealing with TB, I will not give up till we will do whatever it takes to end TB by 2030. So with that, I move to my friend Tereza. If you can just introduce our first panel speaker, or his first question. Thank you.
Yes, thank you, Lucica, very much. Impressed, as usual, by your very passionate speech. And you are right, you are not wrong. And I agree with many of your points. But again, looking at COVID, we are learning, we are looking, we are comparing, we can see that everything is possible when there is a high level commitments, attention, and investments. And even in the short term, you can receive 10 different effective vaccines. And so everything is possible. Now our task is to attract this high level attention. And of course, this attention should be supported by funding. So that's why my first question is to our colleague and good friend Eliud from the Global Fund. What role, Eliud, you think do international funders play in ensuring we are implementing the latest guidelines and policies to end TB? Indeed, we've, despite of all our challenges, we have updated and much better opportunities to diagnose and treat people with the TB. And if we will only implement them all everywhere, we will see significant difference and progress. So, floor to you, Eliud.
Thank you, Tereza, and thank you, everyone. Good morning, good evening, good afternoon, colleagues, and very grateful to ATC and Union colleagues for inviting Global Fund and me in this important discussion. And I like the way Lucica put it as a devil advocate, that she hopes we will be able to end TB in our lifetime or in 2030, but at the same time, she's also skeptical. And I like the heading, why not now? And I would also like to argue that we will be able to end TB soon. And I'll give also my argument, and probably that will also help to generate discussion to our audience. But first, I'll start with the question which you, Tereza, you just asked. And it's true that international funders such as Global Fund, they are critical on really ensuring that the latest guidelines, policy, and tools are being implemented, they are scaled up and used by the country. Global Fund, being the largest international funder for tuberculosis, I think is critical into this. As Lucica just highlighted, in the Global Fund funded countries, according to the global plan, it's estimated that 10 billion is needed every year for the TB response in those countries. And out of that, 4.3 comes from the domestic funding, about 1 billion from international funding, which majority comes from the Global Fund, and then we have a gap of almost half of the response. And so it's critical that even the little money we have, we use it efficiently. And I think what we have seen in the Global Fund is that even countries where majority of the TB response comes from the domestic funding, they still rely on the international funding for some of their intervention, especially when it comes to the latest tools and the latest guidelines. I have a number of examples from where we are funding, where the government is comfortable to take other activities, but when it comes to the latest guidelines, latest tool, they normally rely on international funding. And I think the reason is because most of this government, when you look at their funding cycle, the government funding cycle takes time. So it takes time for them to be able to incorporate anything which is new or any latest guideline into their government funding. So in the gap, in the time where they are waiting for the government funding, they rely more on the international funding. But also I think it's because some of this intervention, they are new. Sometimes somehow they are risky intervention. They want to learn, so they rely so much on the international funding on those aspects. For us, we fund almost every intervention, but when it comes to the latest tool, latest guidelines, even in countries such as India, South Africa or Eastern Europe, where majority of the TB response comes from the domestic funding, we find that government are requesting Global Fund or other international funder to support those latest. One example is when in 2018, when WHO changed the MDR-TB regimen to the shorter oral regimen, Global Fund was very quick to support countries on that. I think within 3 months of the recommendation, we were able to mobilize about 50 million. And we got a request from a lot of countries in Eastern Europe to support them to switch to the newer regimen. Although most of them, the response comes from the domestic funding, but we got the request to support them on switching to the newer regimen. Another example is India, for example, when they wanted to scale up PPM, the new PPM with intermediaries. It was first piloted by a lot of partners, Gates and others, but they requested the Global Fund to support the scale up with the agreement that after 2-3 years, this intervention will be taken through domestic funding. And we have so many examples as well in many countries. We don't only support scale up of new latest guidelines, but also sometimes we work with our partners, WHO and others, to generate also data and evidence to change and to put policies. One example was the shorter regimen, where we worked a lot in West Central Africa to generate evidence which were used to be able to set policy on that area. One of the key area where we have seen very good progress, and that was pre-COVID era, was really on this initiative on finding people who are missing from treatment. And we launched that initiative together with WHO and StopTB. And in 2018, for example, we were able to get additional 1 million patients, and this is, if you compare to the baseline. So this were additional, and we are making a lot of progress even in 2019 before COVID with that initiative, which we think is good. And we were using, and the WHO and others were helping to roll out the latest guidelines, the latest technology to be able to get patients who are missing. And we were making a lot of progress before COVID. Of course, with COVID, we know that the TB response has been reset for many years, but there's also opportunity. That's where I was saying that I'm very optimistic that we will be able to push even in the COVID context. And my optimism comes from the fact that there's a lot of overlap between COVID and tuberculosis. There's a lot of attention now in public health, but also a lot of attention in airborne sort of infection. And this is a very critical, it's a critical time, not only for TB, but critical time for the whole global health community to take that opportunity. I think what we see in COVID and what we see is happening in terms of innovation, I think some of this innovation could be used in tuberculosis and things would change. And as Tereza was saying, we don't know. We have seen in the COVID space within 1 year, a lot of things have come. And I think it's critical for us to be able to use that opportunity as well to be able to bring those innovation for tuberculosis. For example, now in the Global Fund, we have this COVID response mechanism, which we are supporting countries. We have seen a lot of countries, for example, applying for digital X-ray as part of the COVID response, but we believe that can be used as well for tuberculosis. And then now in the context of the new strategy for Global Fund, which is being developed, we are discussing even within the Global Fund and also with our partners. Now, we know, for example, a lot of TB patients are being screened using symptoms. Symptomatic screening is the main way of screening TB patients. But we know also from the previous surveys, almost half of the TB patients who were found, they were asymptomatic. So if we continue with the symptomatic screening, we'll be missing half of the TB patient. And we are saying now, when we have this new digital X-ray with CAD, computerized aided detection, which can read the X-ray, why should we continue to encourage symptomatic screening? I think it's a time where we should say that everyone should be screened using the latest available tools, and we should stop encouraging screening using symptoms, and that is possible, and we could agree and put that as a goal for TB. In the next 2-3 years, we should see all TB patients, anyone who we think has TB, is screened using the latest available recommended diagnostic tool. And in this case, a digital X-ray is now accessible. GDF has just put in their catalog. The prices are, going down, and we should be able to encourage that. And that will happen not only using TB resources, but also using resources which are going to diseases such as COVID, because we can use that and be able to scale up. I think things like contact tracing, which is happening in COVID now in a large scale. We have been trying to use that intervention in TB for many years, but if you go to many countries, you don't find a wide-scale contact investigation program. It will be a pilot, it will be a certain part of the country, but now we have opportunity to use the platform which is built through COVID, but also the experience and the best public health practice, which is now done in the COVID, to be able to do that in TB. And of course, someone would ask where are the resources. I think that's where we can use these joint resources, which are available now for COVID, also to be able to use that in TB. There are so many examples I can cite where we could do that. And my experience of working in TB for more than 20 years, I've seen that TB always wants to have a buddy. TB doesn't work alone. I remember when I was working at the national level in my country, we used to have what we call TB and leprosy program. The resources for TB actually were coming from leprosy. We didn't have any resources coming from TB. Most of the resources were coming from donors who were supporting leprosy. And we were able to use those resources to be able to scale up TB. And I remember when the resources were going down, there was even a discussion within the ministry now to put TB as part of the neglected tropical disease because we didn't have a resource. And soon we just found that HIV came in, and then they poured the resources, and we bundled ourselves with leprosy. We had a buddy called with HIV, and we were able to get so many resources and be able to scale up our TB intervention using the resources from HIV. Tereza just said in terms of the incidence decline in Africa, and majority of it was really due to the response of TB and HIV on those countries. Now we have another body called COVID, which is coming. I think we should also, bundle ourselves with this another body called leprosy, and this will really help us to go to the next mile. And I think now it's us, TB community, we need to be very proactive to invite COVID community, if there's that community. I think next time we shouldn't be only TB people, we should invite our COVID colleague. And us, we are, I think, in a better place to be able to work with them than other diseases because of this commonality and the overlap which we have. They have so many resources, they have so many attention, and we could use most of these resources also to fight TB. So I'm very optimistic. If we use that opportunity, I think we'll be able to change the landscape in TB and be able to get the attention it deserves, and hopefully we'll be able to end TB soon. Thanks. I'll stop there.
So thank you very much, Eliud, for your excellent, again, very passionate speech and sharing your rich experience. Yes, we should be built on our experience and sometimes on our mistakes, learn from the current situation. And of course, in the 21st century, we should provide the best available opportunities in terms of diagnostics and treatment for TB patients. You can't even imagine that you can nowadays to put diagnosis of HIV based on the symptoms. So why we should build it for TB? It's again shows inequity in the approaches. We should try to do our best and to improve situation. Thank you once again very much. So definitely we'll be continuing working together even more hard. So now I would like to give floor back to Lucica, please.
Yeah, so it's my pleasure to actually address my question to you, Dr. Jamal. We need to learn from you and your experience as a TB community, but also as individuals. What has it taken to get polio near eradication, and what are some lessons that we can learn in ending TB? Thank you.
Thank you, Lucica, and thank you to everybody for inviting me today. This was a lovely discussion, and the passion is very, very clear. So that's very good, and I'm glad to be here today talking about polio eradication and how it can be maybe some lessons for TB. I think the conversation that was going on here was also very illustrative. It really, first of all, I think comes down from the polio perspective. One clear lesson, it comes down with marrying or pairing, the global level political statements and commitments to real world political will and real world support in terms of funding, resources, making sure that we have all the necessary tools to support countries in need to push ahead. So this so a global eradication program is really a truly global effort. It doesn't come to individual countries. It really goes beyond that, and that, so with the StopTB partnership, that's very clear. We have a similar program within the polio program. We call it the Global Polio Eradication Initiative, which brings together a whole host of partners that are fully engaged and interlinked with the donor communities. But at the same time, you have deep engagements at the regional level through the regional committees of WHO and with directly at the government level. One clear lesson that I think because we started the eradication program in the 80s, following some early successes in the Americas, and then that was followed, by expansion. And a lot of the milestones, a lot of the achievements were done within the first 10, 15 years. The challenge has been getting through that last few countries over the age. It took a lot of effort to get Egypt done. It took a heavy lift to take India, over the age in terms of polio-free, and Nigeria just was declared wild polio-free in last year in 2015. So, and we remain with 2 countries now in Afghanistan and Pakistan. The lesson learned for us will be, if looking at this in reverse, will be essentially identifying, if possible, those tough countries, those very critical countries with high incidence, with maybe political challenges, governance challenges, with conflict, with geopolitical issues, and then maybe beginning to put a lot of resources and a lot of energy upfront. That is a clear lesson, I think, if there is a lesson to be learned from the process that polio has gone through. The other thing is, of course, within each of these countries, again, it came up, the population is not homogeneous. There is huge diversity in each of these countries. There is a highly underserved populations, priority populations, identifying these groups and understanding, the epidemiology at that level, the social context and around that level is very important. And then taking that to the next level, in terms of community engagement, making sure that you are one with the community, and this is not seen as an external input. We have learned hard lessons in many areas around the idea of, how to make sure that the community that you are serving does not see this intervention as an external input, that it is really desired at that local level. And this has been a lesson learned in very tough regions in northeast Nigeria, in Borno, in the Horn of Africa, and of course in Afghanistan and Pakistan. And if we go, the other critical lesson is surveillance. Having, a global system that really is on top of understanding where from the TB perspective, of course, the TB, but from polio perspective, the polio virus is, and making sure that it's not just, looking at some incidence data, but you're truly trying to identify every case, every infection transmission, foci, using every tool in your toolbox. We have, for example, in polio, we have environmental surveillance network that does a lot of supplementary work. We have a global network of labs that does genetic sequencing for every isolate, and we link all of those together. So these are lessons learned from polio that I think can also be lessons learned for any infectious disease, including TB and including COVID in today's world. And then data and data-driven approach. A lot of our data initially was, of course, administrative data, like many other health data, but you clearly see the shortfalls within a short time once you go into an eradication mindset, which is a whole different kind of mindset. When you're trying to achieve zero, every potential pitfall is a problem. So from that perspective, getting multiple data streams from different sources becomes very essential in trying to understand. It's almost like trying to understand the weather. You need multiple tools to measure. As I think Lucica mentioned, Real Madrid and Barcelona. When you shift gears to eradication level, it's really moving from public health traditional to a whole new level. Playing, I used to call it, I used to do other public health work, but when I shifted and I was working in Pakistan for many years, I used to call it, this is like playing the Champions League and coming out from the 4th or the 5th division. So an eradication mindset truly takes that level of change. And maybe I will stop here and give it to the team. Over.
Thank you very much, Dr. Jamal. Thank you. I think we need to borrow you also for our community a bit, to have more of us, especially its experience and all the challenges are speaking very loud, and yeah, I think we need to get also a bit more attention of the people that were really very engaged. I mean the donors and key global stakeholders in ending polio. As I said, I just want to say, it's very traumatic what happens with polio and the form. One of the challenges for us in TB is that, as I said, people that have TB are not that, visible. And also, men in TB, men at active age, are the ones that are most affected. And unfortunately, I feel that globally attention towards men's health is somehow dissipating a bit. That's another discussion to do, but in TB it might be a reason that we don't have enough attention, combining these two things, and the fact that our people with TB are coming from different countries. Dr. Jamal, it's always a great pleasure to listen to you. And Tereza, please go ahead and introduce our next speakers. Thank you.
Thank you, Lucica. And before I would introduce our next speaker, I would like also to thank Dr. Jamal and say probably following your successful stories, soon a lot of experienced and capable people will have less job, less work, and they can join us and support with our efforts and to find missing people and provide care. Let's think about it in future. And now, with pleasure, I would like to give floor to our next distinguished panelist, young colleague. She looks young, Yuliia Kalancha, but she is already well-known, experienced, and hardworking advocate for TB. And my question to you will be, what does civil society want to see change in ending TB? Please share your view.
Yes, thank you, dear Tereza, and thank you very much for such a simple, on the one hand, but such a really deep question on the other hand. And Dr. Lucica, not only you will play now as a devil advocate. So basically, I have a privilege since already some important thoughts been expressed by other colleagues, and I think I will be in line with it. Among decision makers, it is customary to say that no one remembers your failure, but only remember the result that you were able to achieve, but not in the field of the healthcare, because behind every failure, there are lives of people. And basically today, I do not speak on my own behalf. But I speak on behalf of millions of people who are suffering and already affected by TB, and on behalf of civil society and TB-affected organizations who strive to address the challenges and needs of their constituency, as we are talking about key and vulnerable population they serve. And donors in countries are making huge investments in HIV today, and we are jointly trying to reduce mortality, but people continue to die from TB. And unfortunately, this is not a resonant news right now, but even a kind of normal reality that became part of our usual rhetoric during discussion. And when such events are and discussion are conducted, with engagement of high-level decision makers. For us as civil society and TB-affected community, it is very important that such discussions do not remain at the level of rhetoric. And therefore, today, my answer to a greater extent is addressed to those who are presented on this panel. And I understand that most likely I will not say anything new for you, but we will not stop speaking until our voices are heard, and our children will continue to speak with our voices until we see the results. And we continue to walk in cycles, and unfortunately history teaches us a little. And today there is a feeling that, and basically a fear, that perhaps the situation with COVID-19 will teach us nothing as well. And now both donors and countries need to correctly prioritize. We cannot talk about civil society and TB community becoming the central of TB response when neither the state system nor the civil society and TB affected community prepared for this. And there was no proper investments, as it was the case with colleagues in the field of HIV. This was also noted by civil society and TB community from all regions during partnership forum to develop the new global fund strategy. We need a very consistent work with ending cycle, not separate isolated events or activities, but it is important as well when the implemented activities are part of large national mechanism that will lead to the highest return of investments. And today it is unacceptable luxury to stop funding of really effective regional TB initiatives like in the ICA region, which changed the system approach of working with civil society and TB community and which strengthened the health system. And now we are talking about something that countries with large investments from the Global Fund have not been able to do for many years, but such projects are done in just a couple of years and have an incredible impact on strengthening the role of civil society and communities and on bridging the gaps between civil society and TB programs in general. And as Tereza mentioned, the Global TB Report 2020 and the Complementary Deadly Divide Report prepared by StopTB Partnership stated that progress towards ending TB will depend on actions across sectors, underscoring the importance of the national adaptation and implementation of WHO multi-sectoral accountability framework for TB. Because TB cannot be solved by the efforts of healthcare alone. We need all clearly understand that it could not be solved at all if it continued to be approached as a medicalized issue mainly. Because of course new antibiotics are important and it is imperative to start its implementation as soon as possible at the country level. But if the proper system to support people with TB is not in place, there will be a growing resistance to new antibiotics. And no matter how hard civil society and communities try to provide psychosocial and peer-to-peer support, various needs just cannot address solely through civil society and communities' efforts, who basically steer largely depends on donors' money with national budget allocation to support their work still not being a widespread practice. And civil society work can be in some ways cheap and cheaper, but we are not free. And multisectoral aspects of TB response, like capacity building for stakeholders, including civil society, leveraging engagement of sectors beyond health, sustaining multisectoral coordination and review mechanism, as well as piloting on MAF-TB assessment as a promising development should be a high priority for donors and national governments. And now, in addition to what I have already said, if we really want to see changes in ending TB, we need to stop just fighting fires. We need the political will of all decision makers, and everyone must unite, and not just separate individuals who alone cannot do anything, but we need to invest in those who motivation never ends, who can catalyze and sustain the political will to deliver on the political declaration of UNHLM on TB targets and commitments, pushing governments first to adopt policies for community-based TB service delivery and funds for it. The second one, to enhance CRG activity, because this is an area is not sufficiently funded by both donors and country, and accordingly, there are not enough activities implemented. The third one, to develop urgent mitigation plans in order to reduce COVID-19 impact on TB, because many governments were not able to prepare such plan. Instead, resources from TB response were mobilized to COVID-19 response. The fourth one, to strengthen the treatment follow-up and support, as well as active TB funding, with mobile team based on the COVID-19 expert experience, equipped with mobile digital device with artificial intelligence function for TB detection. And basically, we need true network for finding groups at their place of stay. And the fifth one, we really need increased funding for the development and early introduction of the new TB vaccine, because we saw with COVID-19 that when the health issue is reality, is really a priority, and when it became a reality, the resources and technologies are in place and vaccines are developed in the shortest possible time ever. And finishing, I would like to say that we cannot go back and change the beginning, but we can start where we are and change the end, because life lessons in the fight of epidemics will be repeated until they are learned. And thank you for the time allocated for civil society. Over from my side.
So, thank you very much again, Yuliia. It was very impressive and a very clear statement. And I know that behind this statement there is a lot of work, and your voice is not only your voice; it's voice of the whole community. And it's time to agree and to highlight that. Community efforts, civil society efforts are not something complementary or additional. It's essential, and it should be clearly visible. It should be clearly well funded, and we can definitely see then the difference in our approaches. And we can see also, it's great to see that we are so unanimous as a TB community, and it's a kind of positive side effect probably of this situation. We are close to each other, we are communicating on regular basis, and your requests are fully aligned also with the top 10 requests from the UN Secretary General report. And we are putting up front altogether TB death. And we are saying about missing people, how important it's to find them timely and provide by care. But TB death, these numbers are really crying and shouting. And when we are using as an excuse the points that we need more data, more clarity, etc., data is there, and the fact is that we're ignoring and not addressing adequately these big numbers. So it's time to make the decisions and to translate all our commitments into the concrete actions supported by real funding, including from different sectors of economics. Thank you very much again. And with this, I'm giving floor back to Lucica.
Thank you very much, Tereza. It's a pleasure to introduce a personality for me, Professor Habibe. Your expertise, your hard work in a country that could lead actually in the efforts that are done. Not yet there in terms of TB, but I hope Bangladesh will go in that direction one day in terms of the TB fight. But the question is actually broader, linked obviously to your expertise. How do we ensure the cross-government responses to the TB emergency? How easy or how difficult is that? So thank you, sir. Please go ahead.
Thank you, moderator. Thank you, ATS and Union, for organizing such a time-demanding event. As you know, tuberculosis, we say TB, we are one of the most sufferer country in the world, and it is the ancient disease. Fortunately, it is preventable and curable, but 1.5 million people die every year because of TB, and it is one of the top 10 infectious disease and one of the top most infectious killer. And 10 million people every year get affected, including the children worldwide. And most of the people in the country, they suffered in the low or middle income countries. During COVID, the prevalence, incidence, and number of the patient has gone up. And also the treatment facility, the delivery system, the supply chain, all is disrupted in different countries. From 20 to 70% services were not given last year. In our country, I'm not talking about the country as a whole, but as you see, that usually in every 6 months or every 6 months, we have about more than 150,000 or so. But now, because of our priority has gone back to other places like COVID, that's why we are not giving priority to those priority we used to give before. What's happening? Because tuberculosis is a disease of low-income groups, usually. And during this pandemic, last almost 2 years, we have the attention has been diverted. The money is pouring on vaccine of COVID, not pouring to the tuberculosis, other infectious diseases, even non-communicable diseases. So this is the problem not only in our country, is a global problem, and we have to look into that. How we can correlate and cooperate with each other. First of all, as you know, that I was looking into that because we have a WHO and there is a committee they deal with globally. But for this TB caucus, there's a global TB caucus. They're also their presence in different countries as well. But the decision makers, they need to think about it's a priority. Are they thinking about that? Because they're thinking so many priorities. Tuberculosis probably not in their list at all. So we can, those who are working with TBs to prevent TB, to end TB by 2030. I'm an optimistic man, but still I think it's a very, very optimistic idea that by 2020 ending TB, because the way it is going on, 2022 we are not achieving the target. We know that in 2030 we have to have some decision among the world leader. As you know, the high-level meeting was in United Nations. That's a good move, but the commitment majority of the government has done, they have not fulfilled their commitment. Not even their country, not in the global fund, as far as I know. Plus, what we need to do that we are now is a global village. We can share our best practices. We can share our data. How can we, or we can, as the researchers going on. I still remember when I was, I'm not sure I remember or not, but you know, there is a 2 mark in my hand that we have got BCG vaccination, and still it's working. I am not affected anymore. But many of the countries, and even in our country during these last 2 years, the vaccination program has gone down, so number of patients is increasing. As you ask me how globally we can help each other, we need to find out a platform. Of course, there are many platforms there, but you can involve the public representative, you can involve the civil society. Like I can suggest you that as an Interparliamentary Union, there is a health committee. If you get involved with them, of course, when I was the chair of that committee, I saw Global Fund representative was there, and they used to share our information among ourselves. So that is the one issue, Commonwealth Parliamentary Association, or because it is difficult to involve the decision maker, because as I said many times, that their priority is different, political priority is different. So if we can make a COVID vaccine in Bangladesh in 100 millions, the government will be very popular. It will cross the next election. But if we do not want to spend same amount of money, because I know there will be no effect on next election if we bring, instead of COVID, if I bring any tuberculosis. So there is a lot many equation. I don't want to go details of that. Thank you for giving me the time, and I am happy to, as a public representative, as a cardiothoracic surgeon, I want to involve and help if I can, and I want to work with you. Thank you very much. I'll stop here.
Thank you very much, Professor Habibe. We will definitively need your voice and your support, not just in Bangladesh, but in the region as well, if we want to go ahead and have some hope that we will end this disease. So we finished our panel interventions. And we have now, as we promised, around 25 minutes of possible discussions, questions and comments. I am very happy I imagine me and Tereza on the fact that we have already 3 or 4 questions in the chat. So I also observed that we have 130 people in the audience, which is great. I think we were as high as 170 at the point earlier in the chat. Some people gave up. Anyway, so I think what I suggest we do is, Tereza, we go by question, you know, me and you, and then we see to whom we address it. I can start with the first one, which is about the domestic funding, and then I would like to see any reflections from any of you there. I will try to say something. I will pass to you, Tereza, and then anyone on this question about the domestic funding. And then we have a second question, which I think is going directly to Eliud, and so on. So the first question is about domestic resources, basically, and you know, the question is, to what extent is the inadequate domestic funding a barrier, and at what extent can the affected community members influence the level of domestic funding for TB elimination? So I'll just say a few things, then I will invite you, Tereza, Yuliia, and Eliud in this order. And then, you know, and then maybe Eliud, you can also link your answer to the next question, which speaks about the funding going from the Global Fund to TB, you know. So then, Tereza, you just go then to question number 3. So on the domestic resources, my answer is normally, you know, countries that are affected by TB should put resources needed for all their people to get access to the right packages of care. I want to say that if COVID showed something, showed that money are not an issue. When you have a problem, you can find the money. It's just that indeed diseases are not prioritized. Sadly, in TB, we have huge gaps in domestic resources to go to TB. There are some countries that are the front runners, in which from the high burden countries or the countries with a burden, there are some, and I think, Tereza, you'll mention a bit about BRICS and so on, that put very well funding from their own resources, but we have as well countries in which their contribution to their TB budget is minuscule. In African region, the TB programs are up to 90% dependent on the Global Fund resources. So if, and Global Fund is putting what they have. It's not that they have all the money and then Global Fund puts 90%, government puts 10%, and we are done. It is Global Fund puts 90%. It can be just very little. The domestic puts again very little, and then there is a huge gap. And that is the situation in the entire African region. It's a disaster. So I will just go to, knowing the time, maybe Tereza, you, so yes, we have a problem with the domestic resources, is linked to what Dr. Jamal, Professor Habibe said on the attention of the stakeholders to the TB problem in the countries. And Yuliia will say, because indeed the civil society and communities can strongly push for that. But Tereza, why don't you go ahead, and then Yuliia, and then Eliud, so we don't interrupt that I introduce you, just go ahead. So Tereza, please.
Yes, thank you, Lucica. Just a few comments from my side, and it's interesting to see the questions, and they clearly reflect that our audience also think that lack of funding is one of the key problems, current problems for TB community, which affect progress, and it should be addressed as soon as possible. It's quite clear, and we are unanimous. If we will look at some details, yes, gaps are around 50% global gaps, but when we are looking at the domestic funding, but still the vast majority of the funds are coming from the domestic resources, keeping in mind these gaps. But from these domestic resources pool, the most funding again is coming from the BRICS countries. And if we will look to other high burden countries, their coverage is much less than 50%. In some countries, there are no domestic funds at all. And here especially, the bilateral donor funding, multilateral funding is becoming absolutely critical and essential. So that's why we're bringing these questions to the discussions on the Global Fund disease split, and the situation should be for sure changed, and these needs should be addressed. But also another point is important. If you will look at the NTB strategy targets, zero catastrophic costs, we can see that about 50% of patients with TB are facing catastrophic costs, patients and their families. And situation for them is becoming even worse or when they're initiating the treatment, because so it's a very costly still. And even when we are looking at the better and faster and shorter, more effective options, we should invest more in these options. So that's why we should keep this in mind and continue pushing and try to find the better ways to address these needs. And MAF, I think, here can give us additional potential resource for funding, because MAF mechanism is based on the understanding and agreement that resources should come not only from the health sector, from the donors, but also from other sectors like social welfare sector and their funding and other relevant resources. I will stop here, Lucica, and back to you and colleagues. I don't know who will be the next.
Yeah, if I may continue, thank you very much. I think, as a lot of us already said, our experience has shown that there is money at the national and local level. But I think that civil society need to understand that no one will come to them and say, guys, this is the money, please use them. So civil society need to take some action and do some background work to receive this money, and to for the government also to allocate it. So basically there should be and budget advocacy is a process, and there are some activities that should be done by civil society, and donors should support these activities as well. So there should be appropriate capacity building, because budget can be a scary document and at the first, and getting information from the public sector a challenging process. But building the capacity among civil society actors by teaching them how to access and use this information in their advocacy efforts is an integral part of the budget advocacy work. So this is where civil society can work and can support donors investments and to bridge this gap. Also, there should be a huge analytical work conducting routine analysis of budgets and making this work publicly available, because this is a powerful tool to benefit of communities, as well as to keep public officials accountable. The watchdoging as a process of active monitoring on how the government implements its commitments, and includes regular budget analysis, review of procurement processes, and generation of analysis report. And this is very important point, because at this level civil society can find really interesting things, that there are a lot of money because budget spent not in a proper way, or for example they use some drugs that should not be used at the country level, and these resources can be reprogrammed to another budget lines or something like this. So this is very important work, and I know a lot of organizations who work in this area and who already did this kind of analysis and allocated the funds that they found to TB, so and other areas that were not funding before. And of course, there is also need to support designing the new solutions, such as regulations, programs, strategies, costing, intervention, and provide input in the development of public programs. So just not to stay aside, but be a part of this work and to know what is happening at the national level and with national budget. So I think I will stop here. Thank you.
Eliud, why don't you go ahead, please, in addressing, if anything, on the domestic and the co-financing that is needed, and also a little bit on not, on the point related in the question number 2 around the, the disease split. In a way, it's what is the question about, like the resources available for HIV versus TB and so on. Yeah.
Yeah, thank you. I fully agree. Domestic funding is critical if you want to have a sustainable TB response in the country. And there are two components of the domestic funding. What we see, there is commitment to allocate funding for tuberculosis, but also there's a component of follow through the commitment. And that's where a lot of government don't do. They might even commit a budget, but then later on, some of them don't even follow through even the budget they committed. And that brings a lot of challenge, not only to the National TB program, but also other donors such as Global Fund who are supporting, because whenever we do our funding, we do that taking into account what the government has committed to be able to support the TB response in the country. But what we do also when we give money to the country, we also make some agreement with the country so that they should produce counterpart financing from the government, and we tend to work with them, and some of them could agree, for example, to take first line drugs or second line drugs while we are doing the other parts. And we have seen a number of them have been able to do that, and some of the countries have now been able to take at least first line drugs, second line drugs, and that is continuing progressively. But it's a huge work which we need to work together, and I agree with Yuliia. I think the community has a big part to play into that. And we have seen in a number of countries where community has been very active, we have seen an increase in the domestic funding for those countries. So we need to work very close with the community, with parliamentarians, but also to do those kind of advocacy and analysis to know what the gaps and how we can really make governments accountable and increase their commitment to the TB response. When it comes to Global Fund, yes, Global Fund disperses about 4 billion a year to more than 100 countries, and about 18% of that goes to TB response, which translates to about 700 million US dollar per year. Of course, that seems like small compared to the funding which goes to HIV, which is about 50% of all funding, and also malaria 32%. And now there's a discussion within Global Fund and partners about that global split. It's a difficult discussion, as you can imagine, because it's a zero-game sort of discussion, because if you want to increase in TB, then you have to take somewhere. The TB argument is very compelling in terms of why should TB get more funding. I think the biggest challenge is really to where do you take that funding and how that will have effect not only to that disease but also to the whole funding architecture which we have in the Global Fund, because our funding architecture takes into consideration the burden of the disease, but also the ability of the countries to pay. So that's the whole discussion. But our board will be convening this year to discuss on that and to see how that can be addressed going forward. But apart from that, we normally disburse about 1 billion for supporting health system. This is embedded in some of the disease, but also it can be available for cross-cutting element. And TB being dependent so much on the cross-cutting element, I think we could still benefit a lot from that stream of funding. It's a difficult one, but if we work very closely to make sure that we take advantage of cross-cutting intervention, there's an opportunity to get even more resources, not very much for the TB, very specific, but also the ones which are going to the cross-cutting element. So that's what I can comment on that part. Thanks.
Thank you, Eliud. Tereza, you want to lead on to pass the next two questions? Thank you.
So yeah, thank you, Lucica. And actually, I like questions coming from the audience very much, very strong, clear, and we should be also the same in our responses. So question from the audience, resources are available for leprosy, COVID, why not for TB? is there a communication gap between TB program manager and government resource provider? So very interesting and concrete question, and I would request distinguished panelists and Lucica just try to give your view on the main reason of the current situation, just in 1 or 2 brief points. So probably I will start myself, and I think I put this question for me many times, and how to overcome this current status and why it is like this. And probably the main reason for me is in huge stigma and inequality in TB and for patients with TB, for the poorest, for those most needed support. Because we see if it's needed, even despite of all the economic challenges, the resources could be found quite fast when there is understanding of the threat, when there is a commitment and willingness to improve situation urgently. And of course, when we are looking to the so-called old chronic disease which exists for the centuries, and it's not fast developing disease, and people are not dying immediately. Unfortunately, it creates impression that the response and investments could be also delayed. And we are trying again and again bring these issues of equity. So all lives matter, and we can't tolerate anymore to these growing numbers of TB-related deaths, fully preventable and treatable disease. So that's why if we will manage together to overcome this stigmatization of TB and the issue of inequalities, I think that then we will have a chance. So who would like to share points and try to respond to this question? Lucica, probably you.
Yeah, I will be just very short, because I wonder if maybe Dr. Jamal is a, you are from the outside, right? You are looking at us. It's an interesting question here that I'm not sure we will have time to go to because of the time, but like the last question saying we speak about these same things for so many years, nothing new. And the reality is that for so many years we try to get something new in the TB, but it's not that easy. But anyway, I don't know, my point will be like, I don't think we, I think it's very much linked to the fact that TB was always affecting people that are, as I said, not in the eyes and the face of decision makers, either at the country or at the global level. And that's why it was never attracted even for developers to put their money in to have new tools and stuff like that. But I don't know, I was wondering if Dr. Jamal, you have a perspective for us, like, why it's so difficult to get the attention and the money for TB when others seem to be more successful?
That is a very difficult question to answer, to be honest. Thank you, Lucica. Let me try. I think having worked in public health now, I think for close to 20 years, there's a lot of competition. Let's first of all understand that there's the same donor communities and some global actors have a lot of competition. Polio eradication has been a top public health agenda at the global level since the mid-80s. But subsequently, we have had major initiatives, whether you're talking about TB, malaria, HIV, and now COVID, other diseases like cholera coming up. So there's a lot of competition. But there is one undeniable truth, which is the burden of TB is very, very serious, very global, and has a very high impact, especially at the most important age groups. It's really affecting a lot of people. So that is absolutely clear. Why are we not reaching? I think it's a combination probably of seeing TB as part of the furniture for all intents and purposes in many geographies, like something you live with. I come from a malaria endemic country, and we used to see malaria in the same mindset, something you get like the cough and the flu and what do you call it, malaria. And I think the first thing is to maybe somehow step back and make the goals absolutely clear. and align our priorities around that. If it is ending polio, it's very clear, it's zero, no case whatsoever. That milestone is extremely clear. For TB, I think that clarity has been achieved to a certain degree. The second component of it is concerted multi-level advocacy at the highest level to put TB on the priority. It took a lot of effort for HIV to be on the top list. COVID was a no-brainer because of its high impact across the rich world, but you don't see the same impact on what do you call it, at least from my perspective, the way I see it, for many of these other diseases, including TB. So getting that advocacy is absolutely critical. But also from the epi side or from the technical side, I think there is always a competition between providing resources, spreading it thin, providing resources equally across different risk categories, or trying to really put all your chips in 1 or 2 or 3 or 4 places, or somewhere in between. If ending TB is a very important goal, I think one of the other goals could be selecting maybe 1, 2, 3 high burden countries to say, let's knock out let's put all our chips on this. That would be my kind of thinking. How do we push and get those 1, 2, 3 countries to over the age, especially countries that are low income countries that will require support anywhere at the global level. And that can really drive, I think, the message home for advocacy. If you can achieve in Ethiopia, you can achieve everywhere, some message like that. So, but that is my thinking as an external person who's not engaged deeply in the day-to-day issues of TB. But I think it's a lot of work. But one last comment though, and you mentioned Lucica earlier on, the tools. If we can put up do we have the complete set of tools to achieve our goals, also that is super critical. If we do, then I think the next steps should come in more heavily. Over to you.
So thank you very much, and probably in the interest of time, we are already running out of time. So I'm wondering if you can, we can extend a little bit and have a few more questions. So I would ask Eliud to respond to the question, the MAF-related question. There were a lot of words said about MAF-TB and that the need that we need to be united. And are there any ideas or funds, global fund plan to invest in this issue? Eliud?
Yeah, I'm not sure if I got the question right, but is how Global Fund putting more funding to, was that the question, Tereza?
So, once again, so are you have any plans to include MAF-TB in the Global Fund plans?
MAF-TB?
MAF, Multi-Sectoral Accountability Framework.
Okay, good, yeah, thanks for that. Yeah, I think that our approach to supporting countries is really based on the country request. So we are really based on what country request and we put there. And most of our application is really based on the national strategic plan. So the country develop their national strategic plan, and then based on that, they develop their funding request, and then it comes to Global Fund, and then we fund that response. And most of this is really aligned with WHO. So if most of these activities, they are being funded, and we help countries to be able to develop that multi-country, multi-sectoral approach to tuberculosis. But also us working across the disease, it's not only TB, we support HIV, malaria, but also we have forum with ministries of finance, for example, where there are most of our PR, they're Minister of Finance and also private sector. So we have a forum as well to engage other sectors. I think going forward, we might need to use better our forum We have CCM, for example, where everyone sits in the country, where you have people from different sectors sitting together. I think there's an opportunity even to increase the visibility and get all these sectors to be working together for TB. So there's more opportunity which we can explore and work. But of course, we support countries whenever they think this will help them.
Yes, thank you very much, Eliud. And I would like to add that the beauty of the multi-sectoral accountability framework is on in the principles of engagement of all stakeholders and meaningful contribution and accountability. And from this point of view, definitely Global Fund will play a key role, but the overall responsibility should still be with the country highest level official decision makers, and their efforts and all the work should be reviewed at the highest level and monitored. So there have been questions about BCG and joint vaccination, BCG and COVID in children. So it's not purely relevant to this discussion, but we know that the data for COVID vaccination for children is now limited. We don't have enough information, and BCG we are mainly using for the young children, and today they are not newborns, they are not eligible for the COVID vaccination according to the latest information, but we will keep you informed. COVID is not purely our subject. And the last question, which I liked very much, so we are bringing from year to year, Lucica mentioned these arguments, the same arguments, and and we can't see the appropriate results. So, and how we can respond. So what should be changed? In fact, the arguments, the reasons are indeed the same. So it's the biggest killer, and it's everywhere, and we have targets, and we should achieve these targets and provide access. But these issues are still not addressed because of different reasons. But if you will look into the details, we are changing on regular basis our approaches, trying to find the best ways to address. We are proposing a new vision for the more comprehensive care with a strong accent on the prevention as a whole and the TB preventive treatment in particular. Also, we are now trying to promote this multi-sectoral accountability framework vision as one of other potential drivers of the whole progress in TB. So if you will look at our web resources, you will find a lot of new ways and new approaches, but the principles remain the same. All lives matter, and TB patients and their needs should be addressed. So I would like, maybe Lucica, give floor to you and other colleagues if you would like to say a few words in conclusion.
I think maybe we go one by one, just like 10-30 seconds each, in saying, okay, we are faced with this target of ending TB by 2030. You know, what is one important piece that we need to have that is like essential in our opinion to end TB by 2030. And you know, what I will say that we need the most important, in my opinion, is innovations, having innovations and being able to embrace them. So I will, Tereza, I will come to you the last. So maybe I go now to Eliud, and then Yuliia, Dr. Jamal, and then you, Tereza. So.
Thank you, Lucica, and thank you, colleagues, for this exciting forum and discussion. I think for me, we should continue to push. The task is daunting. But we can end TB in our lifetime. We should not accept the status quo, you know, and let us push. Let us also use the opportunity which are available. COVID has really regressed the TB fight, but also it could be opportunity where we could use the flat platforms which were created for COVID, the advocacy. To be able to push the TB agenda. And of course, I agree, innovation will be key. Thanks.
Yuliia.
Yes, thank you very much. So, yeah, I would like to say that it is very important, as I already said, that that it's now not just to leave everything as rhetoric, but I believe that each of us will reflect and be able to start changes at his level in order to change the situation with TB. And I very clearly saw today what we need to work with as civil society. So thank you very much for this discussion.
Thank you, Yuliia. Dr. Jamal.
No, thank you, first of all, for inviting me and getting me engaged back again in TB matters. Thank you so much. It's been great meeting everybody. And definitely my take-home message from the polio program side is that push, push, push. I think the program already has achieved a lot, has brought many, has saved many lives, and has taken a huge leap forward. But for that last mile in ending TB and finally eradicating TB in the future, I think it will take all efforts, and it will require every human being to really put their heart and soul in it. So good luck, and hope to interact with everybody in the future. Over.
Thank you very much. And Tereza?
Yes, and we are now at the end of our excellent discussion, and I would like to thank you all for a very interesting, important discussion, raising many great points. As a reminder, I would like to say that this recording will be made available to all registrants and posted on the American Thoracic Society website. I would like to thank our excellent panelists, our amazing audience for putting very challenging questions. We should continue challenging ourselves, because our problems and challenges are miserable and incomparable with the sufferings and hardships of the millions of TB patients and their families. So again, big thanks to the Union, to the American Thoracic Society, to be continued. Please stay safe and healthy.
Thank you. And with this, thank you all for staying with us. Have a great day. God bless you. Thank you. Bye-bye.
Thank you. Bye-bye.
Bye-bye.